A very warm welcome on behalf of entire Dr. Reddy's Laboratories. I am Dr. Abhishek. I am the medical advisor for the field of cardiology from Dr. Reddy's Laboratories. So it's a great honor for me to get introduced to top brains of this country like you. So today we have a great session on one of the potent molecule, that is PCSK9 inhibitors, and in one of the most critical conditions, that is acute coronary syndrome post PCI. How would be the lipid management? Is there any new tools which we can improvise the lipid management post PCI, especially after an acute coronary syndrome, with the new tools available apart from the available standard secondary prevention? So to take us through the journey of this PCSK9 inhibitors PCSK9 inhibitors post PCI, we have our speaker, Dr. PC Manoria, and today we have two chairpersons to moderate this session, Dr. MC Agarwal and Dr. SK Parashar. So they will be moderating the session, and the speaker is Dr. PC Manoria, who is a director in Manoria Heart and Critical Care Hospital, Bhopal. And he was also a former professor and head of the department GMC Bhopal, and also honorable physician, and is a past national president of CSI, API, and many more organizations. He is also a past chairman in the Hypertension Council Asia Pacific Society, and he has been awarded with many awards. The most interesting were Bharat Ratna Award by Honorable then President of Sri APJ Abdul Kalam, and he has been organizing several national and international conferences for the last 40 years in order to educate and improvise the knowledge of young cardiologists and physicians. And he has edited around 33 books and 74 publications in various journals, and he has delivered more than 800 lectures in various national and international conferences. So with this short introduction, I would like to give over the session to our speaker, Dr. PC Manoria, who is going to take us through the interesting concepts of the PCSK9 inhibitors in the acute coronary syndrome setting. Over to you, sir.
Good evening, everybody. So for the next 20 to 25 minutes, I'll be talking on this upcoming topic, PCSK9 inhibitors trigger for a new revolution in ACS. All of us know ASCVD is the leading cause of death throughout the globe, including our country. And lipids are the most critical modifiable CV risk factors for acute myocardial infarction. LDL cholesterol is the building block of atherosclerosis. Although we have 4 pillars of atherosclerosis: activation of the platelets, which play a crucial role in the development of acute coronary syndrome at the onset; activation of the coagulation cascade, which also play a very important role at the onset of acute case ACS; inflammation; and lipids. But what is very important to remember is it is LDL cholesterol which is the initiator and perpetuator of atherosclerosis. And LDL is the main culprit for recurrence of cardiovascular event. If a cardiovascular event is occurring after an acute coronary event, perhaps LDL has not been targeted to optimum levels. And all of us know this is CTT meta-analysis, that if you decrease LDL by 1 millimoles, which is roughly 39 milligrams per deciliter, the reduction in the cardiovascular events by 22%. And lower LDL is always better, so that as you can see in this slide, if your LDL is less than 50, it is better than LDL less than 70. So what are the existing limitations and what are the challenges in lipid management at the present stage of time? All of us know statins is the cornerstone for prevention and treatment of cardiovascular disease, and the king statin can never be replaced. But in real world setting, 7 to 29% of patients complain of statin associated muscle symptoms leading to poor adherence and even discontinuation. The second drug which we commonly use is ezetimibe, but the reduction in LDL cholesterol is only to the tune of 15 or 20% at the most. Bile acid sequestrant, the problem is they are not well tolerated, and nicotinic acid is usually not used because of all the negative trial. Lomepatide and mipomycin are agents which are to be utilized only in homozygous FH because they are very toxic and we don't use otherwise. So clearly there is an unmet medical need for a potent, effective, non-statin agent that will lower LDL cholesterol and reduce cardiovascular risk, particularly in patients who have a very high risk, patients with heterozygous FH, homozygous FH, and those patients who are not able to tolerate or cannot be prescribed the desired dose of high intensity statins. Now, before talking about PCSK9, one has to be very clear regarding the role of LDL receptor, the role of PCSK9. So as you can see here, this is LDL receptor, these curly things which are present on the surface of the liver cell. The LDL receptor gets bind to LDL particle. This is LDL particle. This is taken inside the hepatocyte. The LDL is cleared and the receptor, LDL receptor recycled. So this is the normal sequence of events. Now just imagine if there is increased activity of PCSK9, this blue is PCSK9, this is PCSK9. So PCSK9 binds to the LDL receptor, and this PCSK9 and LDL receptor now binds to the LDL particle. This is taken inside the hepatocyte. You can see LDL is cleared, but unfortunately, the LDL receptors undergoes lysosomal degradation and cannot be recycled. So there is increased activity of PCSK9. The number of LDL receptors on the surface of the liver cells will gradually decrease. We have genetic mutants for PCSK9. Now, if there is loss of function of PCSK9, which means PCSK9 are much less, then the LDL receptors will be able to carry out their function of clearing LDL from the blood, and they will recycle, and you will have more number of receptors in loss of function mutation, this side, sorry. Whereas if you have a gain of function mutation, because PCSK9 is more, so it will be taken inside the liver cells, and you will not be able to recycle the LDL receptor. The number of LDL receptors will decrease, and you will have increase in the elevation of LDL cholesterol. Now, when we use this PCSK9 monoclonal antibody, as you can see here, when you inject this agent, it gets bind to the PCSK9. So PCSK9 now cannot bind to the LDL receptor, and the LDL receptor continues to execute its function of clearing LDL particles and continues to get recycled. And this is the mechanism of action of PCSK9 monoclonal antibodies. So what are the pharmacokinetics of evolocumab, which is the agent currently available in India? Bioavailability is 72%. Tmax is 3 to 7 days. Steady state is seen after 2 to 3 doses, and is distributed primarily in the circulating system, and the half-life is 11 to 17 days. What about the dosage? Usually we use 140 milligram every 2 weeks or 420 milligram once monthly for ASCVD with primary hypercholesterolemia and mixed dyslipidemia, and for homozygous FH, 420 milligram monthly. Now, this is a very important information. What is the extent of reduction of LDL when we use various agents? Now, as you can see here, moderate intensity, all of us know LDL is reduced by 30%. High intensity is 50%. If you combine ezetimibe with high intensity statin, 65%, PCSK9, 60%, PCSK9 with high intensity statin, 75%. And if you combine high intensity statins, ezetimibe and PCSK9, you can decrease LDL by as much as 85%, and which is indeed a great achievement. PCSK9 inhibitors like evolocumab not only decrease LDL, they have a favorable impact on all the components of the lipid. You can see ApoB, reduced by 45 to 55%, LPA 25 to 35%, VLDL 30%, and HDL is also elevated by 5 to 9%. So what has the evidence shown in stable angina with chronic coronary syndrome? So let's first talk about chronic stable coronary artery disease, and then will I talk about ACS. Now this is the landmark 4-year trial which was carried out in patients of stable ASCVD. ASCVD means either you have already suffered from a myocardial infarction or a stroke or a peripheral artery disease. The patient were on optimum maximum tolerated dose of statin, LDL more than 70 and non-HDL more than 100. So PCSK9 evolocumab 140 milligrams subcutaneously every 2 weeks or 420 milligrams once a month was compared with placebo, which is the standard of care. And you can see a phenomenal decrease of LDL by 59%. LDL decreased from 92 to 30, and this decreased CV outcomes in patients already on statin therapy. And you can see the primary endpoint, cardiovascular death, MI, stroke, and coronary revascularization and unstable angina, 15% reduction. And the secondary endpoint, which is cardiovascular death, MI and stroke, is reduced by 20%. So statistically significant difference in the ischemic endpoints. The more is the high risk, the more is the benefit. So you can see this is a subgroup analysis. Those patients who had qualifying MI less than 2 years compared to those who have more than 2 years, you can see the benefit is more when you have a comparatively recent MI less than 2 years compared to those where MI has become older more than 2 years. Likewise, if you have more than 2 prior MIs, as you can see on the left side of the screen, benefit is more compared to the right side of the screen where there's only 1 prior MI. If you have multi-vessel disease, which is again a high risk, more benefit compared to no multiple disease on the right side of the screen. And if you have PAD, that is peripheral arterial disease, again, you have more benefit compared to those with, and those patients of stable ASCVD who have undergone an angioplasty, again, you can see there's a significant benefit in this subset of population too. You can see p-value is very significant in 18% reduction. And the 4-year subgroup analysis clearly shows that those patients of ASD who has undergone revascularization procedure, the risk of coronary revascularization decreased, whether CABG, complex PCI, or complex revascularization. And look at the safety. Safety is excellent, just like placebo, whatever subset you take. Now, this is again a very interesting slide, which you can see that around 10% of patients had LDL less than 20, and whatever may be the LDL level, up to 10 or less than 10, it has shown incremental benefit without any significant serious side effects. So PCSK9 inhibitors, evolocumab is very, very safe, always gives incremental benefit without any significant side effects. And this is again shown in this, whether you are talking of neurocognitive decline, whether it is less than 20 to up to greater than 100. This is the less than 20, and this is more than 100, or whether you're talking of elevation of serum enzymes or CK or non-CV death or hemorrhagic stroke, everything is minimal. And this is the landmark log-off trial, which utilized again PCSK9 inhibitor evolocumab and compared it to high-dose intensity statin. You can see this is statin monotherapy, and this is statin plus evolocumab, and you can see there's regression of atherosclerosis in terms of percent atheroma volume, or if you look at the total atheroma volume, again, you can see statistically significant, clearly indicating that if you lower LDL to very low level, you can even achieve regression of atherosclerosis. And there is a linear relation between LDL reduction and plaque regression. Now, these are the highest risk category for ASCVD, means greater than 30% 10-year risk on statin therapy, and all of them need PCSK9. So you have a clinical ASCVD with diabetes, it is a high risk. No CKD, again, you can see the risk is high. With CKD, again, the high. Recent acute coronary syndrome is also a very high risk. You can see 32% risk. CHD and poorly controlled risk factor, again, very high risk. CHD with PVD, again, high. CHD and elderly, high. Stroke associated with the polyvascular disease, again, is high. And CHD with FH, again, becomes very high. More so if your LPA is also elevated. And this shows higher the risk, more is the benefit, as you can see in this slide. And the ESC 2019 has shown these guidelines, which mean if you are a low risk category, the score is less than 1%, your target should be 116 LDL milligram per deciliter. If you are a moderate risk, which means score ESC 1 to 5%, it has to be 100. If you are high risk, 5 to 10%, it has to be 70. And if you are more than 10, it has to be 55. So this is ESC guideline for the very high risk, 55 milligram is the goal for. And again, for secondary prevention, it is a 1A classification, and for very high risk FH, it is 1C. If you are intolerant to statin, again, you can use PCSK9 2BC recommendation. And for primary prevention at very high risk, it is 2BC recommendation. And when we talk of ACVD, the PAD is also included. So whether it is PAVD or whether it is cerebrovascular disease or whether it is CAD, the recommendation is 1A for PCSK9 if the goals are not achieved with high intensity statin. The Lipid Association expert consensus, for which I'm also a member, has shown little different guidelines, and they are very aggressive because CAD in Indian context runs a malignant progression with a very high morbidity and mortality. So if you have extreme risk, they have created a new extreme risk category. Category A, LDL has to be less than 50. Category B, LDL has to be less than 30. Category B means you have a polyvascular disease, your recurrences occur even when your LDL is less than 50. And this is the category A where it is LDL is less than 50. So let's see what is the clinical data for ACS patients. Now, very important to realize that 20% of patients, which means 1 in 5 patients, will have a recurrent cardiovascular event during the first year post-MI. So roughly 20% are going to have recurrence, and the main culprit is elevated LDL, which has not been slashed down to the target. And the ischemic risk gradually decreases. And this is the current consensus, so that if you have a patient of acute coronary syndrome, you should initiate high intensity statin right from the word go. The guidelines recommend that you wait for 4 to 6 weeks before initiating ezetimibe and more than another 4 to 6 weeks before initiating PCSK9. But if the risk is very high, as I'll show you after a couple of minutes, you can initiate PCSK9 right in the ICU. So this is the current guidelines. You can see in ACS patient, you can initiate high intensity statin 1A recommendation, and you can evaluate LDL 4 to 6 weeks after the 2AC recommendation. And if LDL goals are not achieved after 4 to 6, you can ezetimibe 1B recommendation. And again, wait for 4 to 6 weeks, goals are not achieved, PCSK9, which is a 1B recommendation. Statin intolerance, again, you can initiate 2AC recommendation. And this is the trial AVOPAX, which was carried out in patients of ACS. The PCSK9 was initiated less than 72 hours, and the primary goal was not the clinical endpoint, was change in LDL reduction and the safety and tolerability, because this is the first trial, so people want to see how effective it is and are there any safety concerns. And you can see significant reduction of 40.7% compared to the placebo, which has a high intensity statins. And you can see less than 70 LDL goals is reached by 95% of patients and less than 55, 90%. So this is a very, very effective agent for slashing down LDL to any levels. And this is the AVOPAX trial, which again was carried out in patients of ACS, and again evolocumab was administered in the intensive care 420 milligram compared to the standard arm. And you can see substantial reduction. Day 1, 21% reduction, 4 to 7, 60% reduction. absolute reduction day 30, 55, and percent reduction 62. Again, very effective, and larger number of patients reach the LDL goals at the hospital when they are admitted, or even 30-day follow-up, as you can see in these bar diagram. What is very interesting is beside LDL and HDL, non-HDL, HDL is also elevated. Small LDLs, which are commonly seen in diabetics, a 67% reduction, and LPA is also reduced. Now, this again is a very interesting data which shows how often the culprit lesion and how often the non-culprit lesion develop a recurrent event. You can see the risk of first recurrent MI after 8 years. You can see the risk is more with the non-culprit lesion, and therefore compared to a culprit lesion which has undergone an angioplasty. So high intensity statins and PCSK9 if required must be initiated to minimize this risk, because the risk is also from the non-culprit. Again, you can see the recurrent MI rates related to the non-culprit region. At 1 year, this is the recurrence, but at 8 years, it steeps further. And this is the culprit lesion has less chance of developing MI at 1 year or 8 years. And this shows that Valicum is powered to stabilize the vulnerable plaques and reduce their size. So stability is reduced, which is evaluated by minimum CT density of the vulnerable plaques. Their size is reduced, evaluated by remodeling index of vulnerable plaque. The percentage stenosis is also improved. And this is again OCT trial, which also shows a very interesting optimum coherence tomography, which is carried out at the time of angioplasty. And you can see there are again favorable changes at the end of 12 weeks. The fiber thickness is increased, the lipid arc is decreased, and macrophage grade is also decreased. And in the avelumab arm, there is greater benefit. The fibrous cap compared to statin is increased by plus 54. If the fibrous cap is thick, there are less chances of rupture, and lipid arc is -40, and macrophage density is -5. All are statistically significant. And this is the illustration that you can see that the fibrous cap, which is the thickness is increased after evolocumab. And this is the Huygens trial, which again shows that these vulnerable plaques, the fibrous cap thickness can be improved, the lipid arc can be favorably changed, and again shows the same thing. And this is the near infrared spectroscopy IVUS study, which again shows that the lipid core burden index are significantly independently associated with increase of adverse outcomes, and this is favorably altered by evolocumab. The key issues in lipid modulating therapy is you have to start early. If you start late, there's cumulative exposure to increased LDL, which is detrimental, as we see in the FH groups. The treatment has to be very aggressive, and combination therapy is the rule in the long run to reach the LDL targets, particularly in the very high-risk patient. So what is our take-home message? If your LDL goal lower is better, in ACS, the goal is less than 55, the lipid association slashes down in the extremes to less than 30. So if your ACS is having recurrent events within 2 years, the goal is still less 30, and in hospital administration is class 2A recommendation. So in the very high risk, you can also initiate Valicum in hospital. Significant reduction starts within 24 hours, 60% lower 4 to 7 days, and 9 out of 10 patients achieve LDL goals. ACS, evolocumab plus statin effects on the plaques, significantly more fibrous thickening, so they become less vulnerable for rupture, reduction in macrophage grade, significantly high reduction in lipid core burden index, and significantly greater plaque stabilization. And these agents are very safe. So this shows that when we are faced with a very high risk, we can initiate evolocumab right in the ICU. All the guidelines still recommend, I'm sure they will going to change in future, because the guidelines recommend initially 4 to 6 weeks wait after high intensity statin, then ezetimibe 4 to 6 weeks, and then, which may not be appropriate in the very high risk. So if you have a very high baseline LDL cholesterol, And we know statins decrease only by 50% high intensity, and ezetimibe maybe another 10 to 15. So the baseline LDL is very high, and it is expected that this will not be reduced to the target by statins and ezetimibe. You can initiate PCSK9. If the patient is admitted already on a maximal tolerated statin ezetimibe, you can initiate. And FH is a very high risk, particularly HoFH, you can initiate. Or if there's a higher baseline radiological risk, you can reduce the recurrent events in the most vulnerable phase of CF. So you have a multi-vessel disease of very high risk, you have polyvascular disease, young MI, post-CABG undergoing angioplasty, recurrent MI, or you have difficult to treat lesions, particularly with comorbidities like diabetes, CKD, HTN, obesity, FL, you can use these agents. So what we have learned during the last couple of centuries in the terms of lipid, the 4S and the CARE trial has shown us that high LDL is bad. The HBS trial shows that average LDL is not good. The TNT trial showed lower is better. The IMPROVE trial further showed even further lowering is better. And the Fourier trial has shown lowest is best, lowest is best. So this is the message of the research during the last quarter of century. So what we have achieved, and what is the big message for decreasing LDL cholesterol with lipid? Now, when we look at the issue, can we stabilize the plaque? The answer is universally yes. And we know high intensity statins are power to stabilize the plaque. They decrease recurrent coronary events. Can we reduce the plaque buildup? That means, can we reduce the arrest of progression of atherosclerosis? The answer is very clear, yes. We have the data from the reversal trial, high intensity statin reduce progression of atherosclerosis. The third issue is, can we shrink the plaque? It means, can you regress atherosclerosis? Answer again at the present time is yes. Glove trial with above has very clearly shown you can regress atherosclerosis and make this patient free from cardiac. Can we make the plaque disappear? This is an unanswered question at the present state of time, maybe in future. So the big message is, if you are treating patients of stable coronary artery disease or ACS, you should bring down LDL to target to minimize recurrences. If recurrence occurs, the most important cause, your LDL has not been targeted to the required level. Thank you very much for your kind attention.
So thank you, sir. It was really a wonderful presentation. You taught the concepts in a very clear and crisp way, and you highlighted what is known before and what is the new data and how we can apply this new data in the clinical practice. So the data in chronic coronary syndrome as well as acute coronary syndrome strongly suggests that there is a need for aggressive lipid lowering, and this aggressive and additional lipid lowering obtained with PCSK9 inhibitor added on top of statin has helped in the significant plaque regression and plaque stabilization, which is significantly greater than what could be achieved with statin monotherapy. And all these changes have translated into clinical benefits in chronic coronary syndrome by reducing the cardiovascular events. But in acute coronary syndrome, in a stepwise approach, yes, it has shown the benefit, but early initiation, we are awaiting for the hard outcome data. But definitely the surrogate markers, as you rightly mentioned, the plaque stabilization, aggressive lipid lowering, would help definitely certain high-risk patients presenting with an acute coronary syndrome. So now the session is open for the questions. First of all, I would like to ask our chairpersons, Dr. S.K. Parashar, to give your comments, sir. Over to you, sir.
Hello.
Yes, sir, please.
Good evening to all, buddy. It's a very excellent lecture made by Dr. P.C. Manoria on the use of PCSK9 in acute coronary syndrome. My question is this: is very low LDL is safe?
No, LDL is safe at any levels. Even if you achieve LDL 10, it is safe. The Fourier trial has very clearly shown, and we have data from loss of function mutation of patients, that LDL, even if it is 10 or 14, it is very safe. These patients are sexually active, they are fertile, and they don't have any problem. So, and the previous notion was that it produces a neurocognitive decline. But the current understanding is that the brain cells do not depend for their lipids on the circulating lipids. They can manufacture their own lipids. So this is an old concept that very low LDL can be problem. LDL is very safe, even up to very low level. And the current dicta is lowest is best, with incremental benefit without any significant side effects. I've already shown you the slide.
Should we lower the LDL by 15 milligram, or we should not lower than the 15 milligram? Is there any guidelines about the lowering of the LDL?
No, statins decrease LDL by 50%, the high intensity statins. If your goals are not achieved, you have to add ezetimibe. Bempedoic acid is not available in India. And finally, it is PCSK9. But in the context of ACS, majority of time you would require a PCSK9 because the goals are not achieved with high intensity statins.
What is the statin discontinuation syndrome? When we discontinue the statin, or what are the side effects of the discontinuation of this?
Statin discontinuation syndrome means if you discontinue statins, because statins decrease thrombogenicity of blood, statins improve endothelial function. So if a patient who is taking statins and at the time of acute coronary event, you failed to prescribe statin or failed to increase the dose to high intensity statin, these patients have a very unfavorable outcome because of increase in the thrombogenicity and increase in the abnormality in the endothelial functions. That was first detected by the PRISM trial. So the dicta is, if the patient is on statins, if he is not on high intensity statins, when he is admitted with acute coronary, always put atorva 80 or rovastatin 40 milligram. Never forget to continue statin, which was previously the patient was taking. Otherwise, this has shown to increase morbidity and mortality in the PRISM trial.
Can two patients with similar LDL level have different atherogenicity?
LDL we commonly employ in our day-to-day practice, but don't forget it is the number of particles which determine the atherogenicity risk. So particularly in diabetics, you have a lot of small dense LDL with similar LDL. One subset of patients may have increased this, particularly having more number of small dense LDL. So if you want to have an idea about the LDL particles, usually we do non-HDL cholesterol, or there are some special issues you can go in for an FOB to have an idea of the number of particles. The sophisticated tests are usually not carried out.
My last question is how do you treat the statin intolerance? I'll treat it.
In the Indian context, first of all, you have to very clearly define what is statin intolerance. Statin intolerance means the patient is given statins, you develop muscle symptoms, you stop statin, after 4 to 6 weeks, the symptoms disappear, you reinitiate statin, symptoms again. This is a classical statin intolerance. Mere presence of muscle symptoms should not be taken as statin intolerance. If a patient has a muscle symptoms on statin, you must always do a vitamin D level and the thyroid function test, because both these, hypothyroidism and vitamin D deficiency, commonly produce muscle. If both these conditions are excluded, patient still continues to muscle symptom, then the treatment is you can stop the statin and switch on to pitavastatin, which is usually not associated with muscle symptom. And in the West, the usual answer is a combination of bempedoic acid and pitavastatin. If pitavastatin is not available, which is freely available in India, you can try even lower doses of rosuvastatin, 10 milligram once or twice a week. But pitavastatin is usually free from these muscle symptoms. And if you have bempedoic acid, and if nothing was, the final answer is PCSK9 inhibitors, but they are little costly.
Thank you very much, Dr. Manoria, for elaborating the talk on the treatment of the dyslipidemia by PCSK9. Thank you, the pharmaceutical company who has given me chance to chair the session. Thanks.
Thank you, sir. So, sir, Dr. Papashan Manoria, sir, just to add your point, you were talking to the question sir has asked whether the same level of LDLC is it different in different populations compared. So, as you rightly mentioned, in diabetes there is a high chance of this small dense LDL particles due to high triglycerides and oxidative stress present in their body. In a similar way, does it also apply to all other metabolic conditions like obesity, CKD, and in that case, metabolic syndrome? All these cases will be having this great amount of small dense LDL particles, right? So
That's
compared
why
to
we look at the non-HDL cholesterol, which is a simple method, or you can also get an ApoB, which is not
ApoB,
usually available.
which will give the total atherogenic
Yeah.
burden.
So because ApoB, the particles depend on them. The number of ApoB represents the number of particles of estrogens.
Yes. Sir, also literature and real world studies says that Indian populations have high amount of the small dense LDL particles due to high prevalence of diabetes, lack of physical activity, smoking, obesity, all these things. So, do you think we should not consider the lipid lowering therapy just by looking at LDL cholesterol? We have to make non-HDLC and ApoB and follow a stricter goals for Indian populations compared to the what European guidelines or American guidelines give their targets as?
The notion that we should target therapy by LDL may not be approved, particularly in the Indian context, because if you are a diabetic, you have metabolic syndrome, even at relatively lesser elevation of LDL, you can have events because of small dense LDL. You should look at the LDL particles, which you can have look either by simply by a non-HDL or by ApoB. And Indians develop coronary events at a much lower, much higher, less higher levels of LDL. That is another thing compared to the West. They also develop ACS decade earlier, and coronary artery disease, Indian runs a malignant progression with a very high morbidity and mortality. And don't forget, Indians, you may have elevated LPA also.
LPA. And also the HDL is dysfunctional HDLC is very common in Indian population. So now I request Dr. MC Agarwal, sir, to give your valuable comments on the topic.
So very nice lecture by Dr. PC Manoria for lipid management. I want to ask one question. Does the statin increases the effect of PCSK9 and then increases the LDL again?
Yes, so when we use this combination of statin plus PCSK9, this is mitigated. It does.
Second thing, in 4-year trial, we were using evolocumab along with the statins, or alone we were using this evolocumab?
It has always to be with statin. Statin is the foundational therapy. When we say compared with placebo, it is implied that the placebo group is receiving the maximal tolerated statins. Placebo in a trial means that whatever is the standard of care, that is executed. So it will be compared to statins, maximally tolerated statins.
Then what is the cost of evolocumab in India?
Cost of evolocumab, one injection cost about 17,000-18,000.
And it has to be continued lifelong? It has to be continued lifelong?
At least you should continue for 1 to 2 or 3 years. And what we do in the Indian context, because of financial constraints, initially you may give every 2 weeks, unless you are using 420, which is not available. Then you may increase the interval and keep on monitoring LDL. If LDL is getting elevated, you can again repeat it. But that is not a rational approach. But in Indian context, that is what we do. So that suppose after 2 weeks you measure LDL, it is still at a much lower level, say 50, 55. We may delay it and again measure LDL if it starts rising. But the ideal thing, it has to be continued at least for a few years. Because the longer you continue, the better are the chances. We do not have any data of legacy effects of PCSK9 like statins, which was shown in the WASCOP trial. You take statins for 5 years and enjoy the benefit for the next 20 years. The data may emerge so that if a legacy data emerge on PCSK9, then it will be a good idea to have at least for the first few years.
So thank you, sir, Professor P.C. Manoria, very nice lecture. And I thank again the Dr. Reddy's Laboratory for giving me chance to chair this session. Very nice lecture, informative for all physicians. Thank you very much.
Sir, as you rightly mentioned, the legacy effects of statins over the long term in terms of clinical events reduction has not yet been proved with PCSK9 inhibitors. But at least the legacy effect regarding the lipid lowering is well there with the PCSK9 inhibitor, as seen in the real world practice, especially in Indian patients, where the affordability becomes problem for continuing in once in 15 days dosing. Even once in a month dosing also has done a very good job in maintaining the low LDL levels. No, sir. So there is something called legacy effect of this molecule regarding the lipid lowering drugs. So once you give one PCSK9 inhibitor injection, you will achieve the lowest possible level of LDL within a week or 7 days to 10 days. And it remains at that low level for next 28 days, and it slowly starts rising at the end of 45 to 60 days. So it will come back to baseline only after like 1.5 to 2 months. So even once in a month dosing also has done a good job. But as you rightly mentioned, this is off-label and not rational. This thing. But in case of any affordability issues, or if the patient is really deserving the lipid lowering therapy, then we can go ahead with these things.
But nothing is more costly than the life of the patient. If you develop
Yes.
a second MI, you can have serious consequences.
Absolutely, sir. Absolutely. Sir, and sir, you are talking about the data in acute coronary syndrome, no, sir. So, what is your opinion on this, sir? Will you consider this molecule in the early initiation in the acute coronary syndrome in certain high risk patients, and continue at least for the most vulnerable period for like first 3 to 6 months after an ACS, and then step down to statin monotherapy plus or minus AGT? If not in all patients, in some
Yeah.
extremely high risk.
In the patients who are at very high risk, despite the guidelines recommending after initial trial of ezetimibe, statin and ezetimibe, it is always better to start in the hospital itself. The second advantage is the patient usually gets accustomed to its injection, and we can explain that this is going to be beneficial effect in the long run, because after discharge he may not take even the first dose. So very high risk patient, as we said, if patient has a polyvascular disease, which is a very high multi-vessel disease, patient has already undergone CABG, young MI, HOFH, or even HEFH, all these patients require very rigid control of LDL, and this can be initiated even in the hospital, despite the fact that guidelines do not recommend, because guidelines will want a trial, and we don't have trials of this subset of patients. So guidelines will take time.
Sir, and what about the patients with uncontrolled comorbidities, sir, or multiple comorbidities coming with an acute coronary syndrome, like hypertension, diabetes,
Yes,
obesity?
all comorbidities, whether it is CKD and hypertension, diabetes, all increase the risk. Diabetes in particular, diabetes with target organ damage becomes a very high risk. So all high risk, it is rational to use these molecules even in the intensive care.
Absolutely, sir. So, sir, as you rightly said, the guidelines, the most recent guidelines, European guidelines in 2019, at the time of the guideline publications, the evidence of this molecule in chronic coronary syndrome was very strong. That is the reason why they are upfront given class 1 recommendation in this thing.
Yeah.
But at that particular time, the data of acute coronary syndrome, what all you have presented now, has not been published at the time. That is why they didn't give the class 1 recommendation for upfront initiation in ACS. So they are given like a stepwise approach even in acute coronary syndrome. But data in 2021 has shown a very strong evidence that rather than starting PCSK9 inhibitors after some 8 to 10 weeks, if you can start it in very early phase, you will get not only the lipid lowering benefit, but also additional pleiotropic effects, and all these benefits are there if you start it in the early phase after an acute coronary syndrome. Sir, and I wanted to ask you one small question, sir. Do you accept with the fact that lipids are one of the inflammatory mediators, sir? Whenever there is an inflammation in the body, lipids help in further potentiating the inflammation, sir?
Yes, inflammation is an important contributor to atherosclerosis also, but besides statin, which have an anti-inflammatory effect, we do not have any specific therapy which can safely target inflammation. Those
Sure.
monoclonal and canakinumab was, but there were a lot of safety issues, so that was not approved for therapy. But inflammation still remains an unmet need to target in atherosclerosis.
Yes, sir. During inflammation, the lipids, which are actually in the normal and native form, they get transformed due to the oxidative stress and free radicals. They get converted into modified, more atherogenic lipoproteins like small dense LDL, small dense VLDL, dysfunctional HDL loses its function, triglycerides increase. So after an acute coronary syndrome, there is a state of acute inflammation which persists for at least next 6 to 12 weeks. That is in the first 3 months. So during this acute inflammation, these lipids they get transformed from the native normal form to the modified, more atherogenic lipoproteins. So these more atherogenic modified lipoproteins are the one like small dense LDL, small dense VL. They are the one which go and damage the silent non-culprit plaques, normal coronary vasculature, increase the platelet reactivity, increase the cardiomyocyte damage. So during this period of acute inflammation, can we use all the possible tools of lipid lowering drugs to achieve the maximum reduction in LDL, and not only to achieve the quantitative reduction but also the aggressive rapid lowering? If you see with the PCSK9 inhibition added on top of statin, you see the maximum reduction, that is around 70% reduction in LDLC, 60% reduction in non-HDLC, ApoB, within 4 to 7 days after an acute coronary syndrome. Whereas if you see the statin monotherapy, it will take almost like 3 to 4 weeks to achieve its maximum benefit of 35 to 40% of LDLC reduction. So by reducing the lipids to as low as possible, as early as possible, we can prevent this formation of modified, more atherogenic lipoprotein, and we can save the coronary vasculature and other vasculature from the harmful effects of inflammation. What is your opinion on this, sir?
See, LDL is the driver, rather lipids, particularly LDL is the driver of atherosclerosis. If you don't control lipids, you are bound to get recurrent events. So always try to achieve the target depending on the risk of the patient at the earliest. And that should be the strategy.
Absolutely.
Hello.
Yeah.
Yes, sir.
Actually, statins improve the endothelial function as well as it has anti-inflammatory effect also. Statins.
Absolutely, sir. Absolutely.
Yeah.
Sir,
what about PCSK9 as an anti-inflammatory molecule? What about?
They have some anti-inflammatory. Recent reports have shown they have anti-inflammatory actions.
Okay.
Previously, it was believed they don't target inflammation.
Then the combination of statin plus PCSK9 is very good. Thank you.
Sir, recently there's a lot of literature supporting the pleiotropic effects of PCSK9 inhibitors like anti-inflammatory, plaque stabilizing, endothelial function improving, antiplatelet, and also it has a role in the coagulation cascade also, sir. This PCSK9 enzyme, it increases the half-life of factor 8, sir, which plays a major role in coagulation cascade. So by inhibiting PCSK9, we'll get a good benefit in the terms of coagulation cascade also. So just for the last point, what I wanted to add is this PCSK9 enzyme, it was discovered in 2003 as in one of the French families presenting with familial hypercholesterolemia, and it was labeled as a regulator of cholesterol metabolism by its mechanism of action studied during that time. But the recent research from last 15 years has shown that this PCSK9 enzyme is a very potent inflammatory mediator, sir. It plays a multiple roles in inflammation, like damaging the endothelium, increasing the platelet reactivity, increasing the migrating capacity of monocytes, endothelial apoptosis, all these things. So if you see in our human body, in all states of inflammation, these levels of PCSK9 rise. Like if you see the chronic inflammatory conditions like diabetes, obesity, CKD, or hypertension, smokers, levels of PCSK9 are raised by 4 to 5 times. And if you see in acute events like ACS or ischemic stroke or sepsis, these levels are raised by 10 to 12 times. And it's not just the levels rise, but they contribute to the inflammatory damages on the target organs like vasculatures. So if you see in acute coronary syndromes, These levels of PCSK9 starts rising by 12 hours to 96 hours it rises, sir. And this rise in PCSK9 has a very potent inflammatory damaging role on the vasculature, cardiomyocytes, platelets, and everything. So that is also one of the benefit if you give a PCSK9 inhibitor early in the acute coronary syndrome.
Usually we do not measure because the facilities are not available for measuring PCSK9, but studies have shown, as you said.
Absolutely, sir. Even in diabetic patient, if you see, obesity patient, if you see, metabolic syndrome patient, smokers, if you see, all of them, the PCSK9 levels are elevated. And in those patients, studies have shown, prospective studies have shown, the elevated levels of PCSK9 has predicted the cardiovascular events in those patients. Technical team, is there any questions from the audience?
Please give me a minute, let me check.
Please. Sir, so before coming to the question, so
No,
if
sir,
you,
there are no questions as of now.
okay, fine. Sir, if you initiate in any acute coronary syndrome patient who is at extremely high risk, what time you would prefer to initiate this, sir, and how long you would prefer to continue, sir, in this patient?
If the patient can afford, at least for a few years.
Okay, sir. And when you will plan to initiate, sir, you will plan to initiate immediately after PCA?
If the risk is very high, rather, otherwise also we prefer the first injection in ICU where patient gets accustomed.
Absolutely, sir. So if you give a PCSK9 injection post PCI in the CCU when a patient comes, even before his hospital discharge itself, we would have achieved the maximum lipid lowering. Unlike statins, which we can give in the emergency room because they are oral medication. This is a subcutaneous. We can't give it in emergency because it might prolong door to balloon time. So it's better to give after PCI when the patient comes to CCU. So any other questions, sir, Dr. S.K. Parashar, sir, or
Yes,
Dr.
thank you
M.C.
so much.
Agarwal?
It was a very good and impressive lecture made by Dr. P.C. Manoria, and we have learned a lot about this molecule because the dyslipidemia is the main risk factor for the cardiovascular diseases, and to lower the lipids, it is very important to curtail the cardiovascular diseases and especially atherogenic in nature. Thank you so much for the lecture.
Sir, Dr. P.C. Manoria, sir, there's one question in the chat box. Does PCSK9 inhibitors have a role in reducing triglycerides?
To some extent it does. It has a favorable effect on all the components. But the main action is on LDL and on the LPA.
Absolutely. So, yes, sir. So, sir, regarding this triglyceride thing, no, sir, when the triglycerides are in the normal levels like 150 or 200, when you get PCSK9 inhibitor, you see hardly 15% reduction something in triglycerides.
That is an ancillary effect, is not a measure.
Yes, yeah. But when the triglycerides are elevated, no, sir, like 400, 500, 600, there was a good effect of PCSK9 inhibitor in reducing the triglycerides.
See, triglycerides, even at the present state of time, they are merely a marker because lowering of triglycerides have not shown to reduce cardiovascular events. The reduced trial did show reduction in cardiovascular event, but when the data was analyzed for the subgroup triglyceride less than 150, more than 150, the benefit was same. The secondary endpoint were more benefit in the triglyceride group less than 150. So triglyceride at the moment, we do not have any data that you lower triglycerides, the cardiovascular events are decreased.
Okay, sir. So, Dr. M.C. Agarwal, sir, any final comments from you, sir?
Yes. Is there any contraindication of this drug with the renal failure?
No, this drug is very, very safe. All toxicities have been evaluated. We'll show you that the slide that side effects are negligible. It has not been specifically tested in CKD, but at the moment there's no data.
Sir, in CKD, up to 20 EGFR, we have data to show that it is safe, sir. Below 20 EGFR, that is patients requiring dialysis or anything, we don't have data to show that it is safe, sir. So, up to 20 EGFR, you can safely consider it.
So, I can say this is a very good lecture, informative for physicians. And thank you, Dr. P.C. Manoria, for delivering this lecture to us. Thank you again.
Thank you, sir. So any final comments, sir, Dr. PC Manoria, sir, before closing the session?
I think you should have more CMEs and more interactive session, because still this molecule is not well known among the physicians.
Sure, sir. So thank you, sir. Thank you for your wonderful lecture. Thank you for your very beautiful explanation of the concepts of the lipid lowering. I thank Dr. S.K. Parashar sir and Dr. M.C. Agarwal sir for chairing this session and making it more interactive. So with this, I would like to thank all the audience who have participated, and thank you technical team for organizing this. And thank you all marketing team also for coordinating and arranging this meeting. So with this, I would like to close the session. Thank you. Good night and stay safe.
Okay, bye bye.